Good afternoon, welcome. There it goes. Now it's too loud. I'm Caroline Blom. I'm a senior research scientist here at NCQA. I'm going to sit down. Welcome to our provider perspective panel. And the goal of it is just described by what we're going to talk about and by the title: Strategies, Best Practices, and Solutions from the Provider Perspective. We are just thrilled and honored to have two healthcare leaders here from California, one from Southern California, one from Northern California, Dr. Bihu Sandhya from Ultimed, Dr. Stephanie Brown from Sutter, and I'm going to have them introduce themselves to you in a bit, but they are leaders in the interaction of quality and equity in their respective health systems, and of course they work for health systems that try very hard and are working very hard to provide quality of care for diverse populations, historically disadvantaged populations, and we're very, very interested to hear what they have to say today. I'm going to start with introductions. And I'll introduce myself first. I'll then have them introduce themselves and tell you a little bit about the delivery systems where they are working. So I'm Caroline Blom. As I said, I'm a senior research scientist at NCQA. By background, I'm a geriatrician and palliative care physician for many years. Before I came to NCQA, I was the chief of geriatrics and palliative care at NYU Langone. And federally qualified health centers are very dear to my heart. NYU is affiliated with the second largest federally qualified health center system in the country. And I did a lot of work with their wonderful staff and their group in the years where I was at NYU Langone. I also worked a lot with health and hospitals at New York City. You may know Bellevue. My office was in Bellevue. And so I'm very familiar with some of the issues and some of the strategies that we're going to be talking about today, and very excited to hear from our panelists. Before I went to NYU, however, I spent much of my time in Michigan. I was at Henry Ford Health System for some years, and then I was at the University of Michigan. And during that time, I also had a stint as a medical director of a Medicare Advantage plan, and I also was the medical director of 2 successful ACOs in Michigan. Well, I went to NCQA because I'm very interested in quality of care for complex patients and for people with multiple chronic conditions. And at NCQA, my role is to work on measurement and standard development and even strategy to increase quality of care for complex patients. So enough about me. I'm going to turn it to our panelists. Bihu, would you?
Sure. Thank you. Thank you, Caroline. So I'm Bihu Sandhya. I am an internal medicine physician, and I have the honor of being Chief Quality Officer at Ultimed, which is here in Southern California. My background is, and I'm actually, a passion for me is I'm a practicing physician. I do diabetes care, advanced diabetes care, and I've been in clinical practice for over 25 years. So when I first graduated, I graduated from University of Cincinnati. I was actually asked to be a CMO of a federally qualified health center in downtown Cincinnati, and I was the youngest person there. That was challenging, but you learn. And my career, I've been a medical director of quality for a large non-for-profit Adventist health system in Cincinnati for about 16 years. And I was executive medical director for a physician group for a for-profit system, also in Ohio. And then I came to California over 3 years ago, and I've been now here at Ultimed. And I think we'll get to talk a little bit more about that, but I'm going to turn it over to Dr. Brown.
Thank you. Excuse me. Good afternoon. It's an honor to be here with you. I'm Stephanie Brown. I am the medical director for the Sutter Health Institute for Advancing Health Equity. I am an emergency physician by training. We are the safety net. We see all the dirty details of how our system fails. So if you're wondering how I got into this work, I am born and raised, hail from the south side of Chicago. And in college, I actually studied the history of science and medicine. So it kind of started my adventures into the healthcare system. And I went to University of Chicago for medical school. And that's important to me because I learned medicine from the community that raised me. From there, I did my training in emergency medicine down here at Harvard UCLA. And what better place to really see the perils of our healthcare system when patients are waiting 48 hours in the emergency department waiting room to see us. And gracias, lo siento para la espera larga, right? It's just really, really horrible. And so from there went to learn what do we do about this fixed healthcare system? So I did a fellowship in health policy in DC at George Washington University, got my MPH in health policy, and had the opportunity to study at the CMS Innovation Center just around post-ACA period, learning about ACOs like Caroline's that were successful, and really understanding that it was the social drivers of health when those populations were heavy dual eligible and were still successful. It was really addressing the SDOH. So I learned a lot and came out to California, to the Bay Area, and have been at Sutter Health for the past 10 years. So it's an honor to be here. Can't wait to talk about the provider perspective and all of the things we're learning and how does that translate to the bedside and what are we actually doing.
Great, and before we get started and hear about the delivery systems and dive into some of the best practices and solutions, I was thinking it would be interesting to take a poll. How many people in the audience are physicians? How about nurses? Great. Other clinicians, social work, others? Okay, great, so a lot of clinicians in the audience. It's gonna ring true what we're talking about, so thank you.
So I think I was just going to start with introducing us, which is Ultimate Health Services, and we pride ourselves in being the largest federally qualified health system, not only in California, but nationally at this point. And we cover currently 2 counties, LA and Orange County, but rapidly we are growing, and we can't even keep up, actually. We're growing so rapidly. I think the thing that resonates is our mission. We've been around for over 50 years, but our mission has always been to eliminate disparities in healthcare access and outcomes by providing superior quality health and human services through an integrated world-class delivery system for Latino, multi-ethnic, and underserved communities in Southern California. And I really would say we live our mission. That's really what we're about. And this just shows it started so long ago, but Ultimate it started from one little clinic, and now we're over 40 plus. I've actually lost count because we keep on adding, and so there's so many clinics. This is just a snapshot. It's really not comprehensive of some of what we have now in our system. So we have primary care. We have over 33 plus sites. I think it's more than that now. But primary care for us includes senior care, women's health, health education and wellness, and then we, of course, have the ancillary services. We also have dental. We have behavioral health. We have mobile health clinics. We have youth services. We have a clinician home visit program. We have pharmacy services, not only as our own pharmacies, but we also have clinical pharmacy services in our sites. We have HIV and infectious disease services. And then on-site specialty care. We have a big partnership with CHLA where we provide the primary care for our Medi-Cal beneficiaries there. And now we've added in the last year and a half, 3 others, and that's the transitions of care services where we focus on patients coming out of the hospital. We have a very innovative program called Ultimate Now, where we have 24/7 virtual care for our patients. And we are definitely part of CalAIM, the ECM, and that has been quite a journey, but we do that as well. Just a couple of highlights. We are serving about 500,000 patients right now. We've done at least 1 million primary care visits in the last year, and 34% of our patients are uninsured or private pay. We have a large number of Medi-Cal. That is our base. We have 400 plus employed providers. As I said about the medical centers, we have multiple hospitals. I think the biggest challenge here is we have 15 health plans we work with. We have at least 4, well, it's more than 4, Medi-Cal plans. And we also work with maybe 9 Medicare plans, and then there's commercial. So there's lots of lines of business. And we have specialty networks. There is the part that's unique about us, I think, is we now have over 200,000 of our Medi-Cal or Medicaid patients in global risk contracts. And as of July of this year, it should be most probably all of them. There will be in global risk or full risk. One thing what I think we pride ourselves on, we really feel we are really about quality and health equity. That is what we do. We are payer agnostic in our approach to our patients. Providers really don't have to think about what is their insurance. We just provide the care. We do a lot of the work on the back end so that we try to make that seamless. We have a board that governs us, which is really made up of community members, and we really do listen to them, and they drive a lot of what we do. So I think that's important to have the voice of the customer. And then we have, this had to stop during the pandemic, but we've been focusing on patient experience for the last couple of years, and we've started reinstituting our patient family advisory councils, and we've got 4 sites up where we're doing it quarterly, but our plan at the end of this year would be every one of our sites does patient family advisory councils, so we listen to that as well. So that is about us, and I can hand it over to Dr. Brown.
Thank you. All right, let's talk a little bit about Sutter Health. Our mission is a lot shorter, caring for our patients first and our people always. So Sutter Health, we are made up of 22 hospitals, 6 medical foundations, 2 IPAs, serving patients, more than 3 million across Northern California, a little touch in Oregon, Hawaii, the central coast of California as well. We, as I said, serve over 3 million patients. We have 12,000 physicians for Sutter, 2,000 APCs, 15,000 nurses, 55,000 employees. We span, we are race ethnically diverse, we are linguistically diverse, we are geographically diverse, rural, urban, and suburban communities. Again, we have a footprint in 22 counties in Northern California, and the majority of our patients do not speak English as their first language. So at the Institute, we were started in December of 2020 formally. However, our work really spanned back the past decade, as I mentioned, really starting from initiatives that were born out of the ACA. And that work just continued to snowball. And as we've heard over and over, the COVID pandemic really accelerated everything that we're doing. But our goal is, that all patients receive high quality care regardless of their circumstances. And really at the Institute, we're looking to data-driven, innovative solutions. And that is always done in partnership with our care teams across the care continuum, involving our patients and our communities. And so we really like to think that we are this connector, convener, and catalyst for the work within our system. It's a big health system. And so part of the difficulty is to find the silos, to go into the silos, to break down the walls, to find the best practices, scale them across not only our footprint, but as far as we can go, all the way to the nation if possible. So on the right, maybe my left, your right. The Venn diagram. This is the framework that we use to approach how we close equity gaps. And I'll start by just saying, when we started our institute in December 2020, we were structured under the research division of Sutter Health. Because, as I said, we start with the data, we measure what matters. It's very important to us. However, with our new CEO, Warner Thomas, who's been at Sutter for about a year now, we were restructured under the Quality and Safety Division. As we've heard over and over again, equity and quality go together. And that's really made all the difference for us in Sutter. And we like to say that whatever in your health system, hospital is the engine for changing the way that care is delivered, that's where equity should be. And so for us at Sutter, it really is in quality because at all 22 of those hospitals, we have a quality and safety lead. All the medical foundations, there is a quality and safety lead. And so we're able to really embed our work and disseminate it through the quality arm. So we have 4 programs in the Institute: maternal and birth equity, mental health equity, chronic disease equity, and equity in care transitions. And what's really new for this year is that we have 3 quality measures that are health equity focused, that are paired with overall metrics on our annual incentive plan, which is really great for, again, looking at disparities and closing those gaps. And so what that means is, I'll start with heart failure readmissions. So for 30-day readmissions for heart failure, it's a CMS metric, but in our system, the disparity lies, as does in the nation, with our patients who self-identify as Black. And so we've paired that CMS metric with a metric specifically looking at 30-day heart failure readmissions for patients who self-identify as Black, regardless of their payer. And so if we design interventions in a universal design approach, that means that we are able to close the disparity gap for the vulnerable population, and that will roll up into the overall metric as well. And so everyone has access to these interventions and programs, but we start by prioritizing where the need is the greatest in our system. Under chronic disease, our metrics are hypertension control, specifically for patients who self-identify as Black, and colorectal cancer screening for patients who self-identify as Hispanic. And so that way, again, when we pair that metric with the overall metric, instead of being seen as a double hit, we say, if we design the interventions correctly, and we take a social drivers of health approach, and we look at the data and we look at our patients, and then we're able to really close the gaps twice. The last thing I'll say, and how we really get this work done, because this is a provider perspective panel, is I'd like to just highlight our Physician and APC Ambassador Council within our system. So I co-chair that with another gentleman, Dr. Andy Brothers, who's a family physician in Sacramento. And what this is a council, and we meet quarterly, but it brings together every single clinician who leads health equity work across our system. So we talked about the silos and how it can be difficult to get best practices both out and in those walls. And so we've got now, gosh, our pack has grown so much, over 50 clinicians that come together. And this way, we're really able to do things like discuss these metrics that we talked about, but also find what are your best practices, what are you doing? And now, through our quality and safety arm of the system, we're really able to scale those best practices more rapidly, leveraging technology across the care continuum and really working together in ways that we hadn't before. I think I'm gonna, okay.
Okay. So I think we all really want to hear about the best practices and solutions because they have a lot of great stories to tell. Before I do that, though, I did want to get at the 10,000-foot philosophical level about the relationship of quality and equity. If you want to both say a few words about that, and you both already have, but Bihu and then Stephanie.
Sure. Well, I think we've heard that through the whole, they're completely connected. They're intertwined. You can't do, in my opinion, quality without health equity. And if you're doing population health management, what is health equity? You're really meeting the patient where they are. And if you just design one plan in quality and don't customize it for the different people that you have, you're not going to get quality. You're just not going to get to where you need to be. You have to be very thoughtful. My IT person will say you can't do quality without IT. That's what I hear all the time. He reminds me of this, our CIO reminds me of this literally every week. And I agree with that. I think it's all together. But I think we really, for us, this is how we live at Ultimate. This is what we're about. It is an FQHC. It's all about quality, health equity, about the vulnerable population. All of our patients are vulnerable. Even if you have commercial insurance or even if you have Medicare, you're still vulnerable. This is they are from the same communities that we serve. And the other part I think that's important for us is we have actually in our workforce, 70% of our workforce is from the communities that we serve. They live within 5 miles of our offices, and 80% of them are women. And that's what we found in our organization. And so I think we'll be expanding on programs after. I just want to say one thing. We had JACO show up 4 or 5 months ago. Of course, that was the week that our CMO was on vacation and unavailable, and they just showed up at our office, and we did actually. And the person who was supposed to run it was in labor, so you can imagine what we were going through, but we did it. And we actually really thought about this, and the head, Jaco, when we met with him the next day after the first day, he said to us, and he sat down and he said, I want to tell you something. He says, you provide dignity to your patients. And we could feel that in all of your clinics. And that was, I mean, he just hit it on the head. That's exactly what it's about. But basically, I think you just truly have to do both together. There really is no difference if you do it right, in my opinion.
Stephanie?
I couldn't have said it better. So within our institute, again, we report to the Chief Medical and Quality Officer for the system, and we really work closely with our executive directors for acute and ambulatory quality to, again, run all of these interventions through that lens at Sutter. And so, it's all about being the drop of food coloring in the water. That's what health equity, we're on the same journey that patient safety was before, but this has to be everybody's job. So we're not just sort of this one isolated, another silo, right, where we're just the health equity people. Nobody else has to do any of that work. This is all of our work because we learn there's so many different ways that, what is diversity, right? What are all of the ways that we're different? You can look at the data in many different ways to find out who's being left behind. The equity impact assessment, for example, is not just a race ethnicity tool. It's to really look at where are you leaving people behind in your interventions. And so one of the things that, for our health equity strategy for 2024 and beyond that we're recommending to the CEO on Friday, so you've heard it here first before him, is that the EIA really be an integral part of the strategy for every single aspect of Sutter Health. Every line of business, every department needs to do that. And I highly recommend that any program that anyone does for anything with respect to health equity interventions, clinical interventions, that we all do that and take that moment to really take a look and think hard, because it's not always what we think. And just like we said, we're at risk for widening gaps if we don't think about how these interventions, can possibly leave others behind.
Great, thank you. Very inspiring. And now what we're all waiting for, best practices, solutions, and programs. Okay, want to start?
Sure. I was like, which one do I tell you? Because we do so much. Really, it's just about that. It's actually what I think we enjoy, and I think it's one of our big takeaways is you have to be innovative. I think innovation is really key, and you have to listen to your teams. I have a team, a very, very diverse team, very young, and they're so amazing because they're so smart. And you really need to sit down with your stakeholders and to find solutions. So one of the, I promised I will talk about this, was, so we all do HEDIS measures. I think we're, and I want to say one thing about HEDIS that I feel that's happening now is that we are really looking at the reality of how to get to those measures. We're not just, we're understanding the nuances that it takes, like self-reporting blood pressure, that is important, or even the things with the social determinants of health measures, those are so important. So so colorectal cancer screening, we have 80,000 patients now in our cohort of patients that need this. And when I got to Altamed, we were using FIT kits and we were using colonoscopies. There's a 5-month wait for colonoscopies. And FIT kits, we would get them out. And I'll tell you some of the programs we did, but we would start every year 17%. That's where we were. And then we had to get our way up to try and get to, our goal was 80%, which was unrealistic, but that was our goal. So we would never get there. So, and this is the kind of support we provide. So what we do is we show data at every level every month, and it's all inclusive. Then we also break it down for every office, and I have clinical quality analysts that meet with every office monthly with their data. And we, again, analyze data if you're falling behind in something and give them opportunities. The other thing that we do is we do outreach. So we actually support them centrally with outreach. We have, for fit kits, we use technology where we'll text our patients. It's actually very effective in our population, and ask them if they would like a fit kit, if they qualify. And if they say yes, we'll mail it to them. Well, the other part that we do is we have a health equity institute we've had for 5 years. We partner with them, and we actually follow up on patients that have been given fit kits. Call them 2 weeks later to say, well, how can we help you complete the fit kit? And many times we find they've already lost the fit kit. And so we go ahead and go mail them another one, but we actually educate them. We use interns for that. We use health navigators for this. The other part we do is, which we support for all actually all colon cancer screening. We have, for the Health Equity Institute, we have a grant from the CDC. We do a registry. And we call the patient and we hold their hand and walk them through all the way to that colonoscopy. Because it is so hard for our patients to navigate the healthcare system. I find it intimidating to navigate. I can't even imagine our patients who don't speak the language. And we found that one of the reasons they were needing repeat colonoscopies was a poor prep. So we now have an RN who actually teaches them how to do the prep. And we've been able to, increase it by 50, 60% in 1 year, so that the preps are done right. Because it's all language. We've also developed a telenovela that we send out to them electronically to convince them. And this year I think there's one for males and one for females. And we're now in the CRC, we're in Colorectal Cancer Month. So we have our Grow Healthy campaign, which is run through quality, where we're doing all these initiatives at the office and prizes, so that way they can actually do this. So one thing that we found was if we just continue to do fit kits and colonoscopies, we're never going to get there. We're not going to impact the patients we need to. So I did something which, it was a challenge. It was expensive, but we expanded our methods, and we added a DNA fit kit. So I work with the vendor, and so not only did they, we offer it to everyone, but with one caveat was we said to them was two things. I said, we will only do this with you if you will cover our uninsured, and they did. So we're the first FQHC in the nation that is doing that now. And we got that integrated into our EHR just like everything else. And again, it is not something the provider needs to worry about. We've built it all in. So if you're in a certain poverty level, you can actually just get a DNA fit if that's the right test for you. And they give the same level of support. But we went one step further. I was like, okay, what happens if that's positive? What do we do about that? And so we got a grant from them. And we have relationships with some of our gastroenterologists in LA where we pay from our system. We'll pay for that uninsured patient to have that test done. So that's how far we took it. And so I think one of the things to just showcase here is that this is how much it takes, but it is equity, because what we're doing is we're meeting patients where they are. Some of them can do this, some of them can't. We found that actually our younger patients, the 46 and over, the 45 and over, they prefer the DNA fit. But it is challenging for patients who are 65. So we've developed materials for them that are specific because it's so challenging. We've trained all our nurses, so that way we can actually set up a nurse visit appointment, and they can come in and we can teach them how to do this. So this is the level. We have videos in our offices that you can turn on and leave for them to watch while we're actually, so that they understand how to do it. So this is the level of what it takes to get one measure done, which is colorectal cancer screening. Thank you.
Okay.
So I'll talk about heart failure readmissions, because, let's just jump right in there with a really difficult, a challenging opportunity in our health system. So actually at Sutter Health, we do quite well with 30-day readmissions overall. And so we really took it to the next level and looked at the real issue for us is heart failure. As many of you in the room may experience, it's just a challenging disease to navigate. It is the it is a remarkable demonstration of the, like I talked about, the ills of our healthcare system. How do you transition from the hospital back to the community that you come from? It's critically important to be on the right therapies. And in fact, your mortality depends on it in 1 year. And beyond that, you know, there's different people are paying for your care, different insurers. And so, you know, on our hospital side, someone with heart failure comes in to see us, and then they're discharged. That's just a whole big question of now what? We are responsible for keeping them out of the hospital for 30 days. However, many of our patients are not, our hospital patients are not necessarily impaneled with us with primary care. Many are with specialty care, but it can become more difficult to see them once they leave the hospital. And so this metric is particularly challenging for us, but we feel like we get to take it on now. And so really what we've done is try to shore up all across the care continuum. So the ambulatory side, the emergency department, as well as the inpatient. And so this kind of speaks to the power of that system approach. So our JCO, one of our hospitals, for their health equity quality intervention for JCO, looked at heart failure readmissions for Black patients. And they were wildly successful. They created their own nursing-based intervention. We've got standard work down to the minute for what to do daily from the point that a patient is admitted to the floor. And they just start with the education and the reinforcement. It doesn't matter what time they get to the floor. The process is the same. And so they do that every single day. This teach-back approach. The patients are teaching the nurse. When they come in, it's like, okay, what happens now? I say, okay, I'm going to weigh myself. This is how much I weigh today. All of those things are reinforced. Average length of stay is 4 days. You've got multiple opportunities to teach the patient on every single shift so that it really sticks. We have integrated our social drivers of health screening within Epic. It was also an opportunity for us as of January 1 this year to refresh our REAL data collection as well as look at our SOGSC data. And we're also moving this year to also collect disabilities. We work really closely with our research colleagues at Sutter Health. One, a colleague of mine just told me she's really looking at functional status for patients with heart failure. If you can't walk across the room, your likelihood of being readmitted to the hospital is much higher. So we're looking to integrate both awareness into Epic. So you open a chart, boom, this person was in the hospital within the past 30 days with heart failure. Looking at, you know, this person cannot walk across the room. That makes a big difference in the type of care they need, the type of home care that they need. So understanding those things. And so those are some of the things that we do on the inpatient side, as well as starting patients on the guideline-directed medical therapy for heart failure. So our research colleagues have redemonstrated the exact same data that we see for the nation. The gap for heart failure disparities is widening for our Black patients, and the 1 year mortality for those who are not on guideline-directed therapy is just wild. And when you get onto the therapy, 3 or 4 drugs, it goes down. The readmissions go down. And so what do? Half of our patients in our health equity metric have Medi-Cal. The other half do not. And so now we're looking at who's paying for these meds and what do we do? But this is health equity in action. We have a virtual pharmacy program at Sutter Health, and so we are spending our time trying to identify how we get every single patient that meets our health equity metric into that virtual pharmacy program, regardless of who pays for their care. Because it's not just for readmissions, it's not just for some executives' bonus, it's for mortality. And this is what we're doing. So we've got access to pharmacy, addressing the social drivers of health. We partner with our managed Medi-Cal payers to really bring to life all the CalAIM benefits that we're talking about. In Alameda County and Contra Costa County, we are working with a care transitions organization that contracts with those payers. in order to shore up and really provide those care transition services, medically tailored meals that we heard about in the last panel, all of those things, and the enhanced case management. And so, again, if those types of pilots in our system are successful, and in the East Bay, that's where our disparities are the worst. When those are successful, then we're looking also at taking it further, as we heard, the community care hubs model. Some of our care transitions partnership work that's already being done in our hospitals, we're looking to expand that to make them become community care hubs as well. And then the last part is when people come back to the emergency department, we do this whole assessment all over again. We're building within EPIC the automatic case management consultation, going back through the social drivers of health, finding the root cause, because we know that not everybody that's in the emergency department is there because they're in decompensated heart failure. They're in decompensated something, but it may not be clinical all the time. And so we take that opportunity while we're doing our clinical assessment to also invite our colleagues to help us to find the other root causes, because what we can't do is put all of this expectation or weight on one clinician or one team. It is a collaborative approach, and so at every door, at every part of the continuum of care, we're trying to shore that up and really get at the root causes, and then provide the resources that we know will reduce not only the readmissions but the mortality.
Yeah, this is great. So that's just a taste of some of the amazing programs that exist. And just thank you so much for describing them. We actually only have about 10 minutes left. If anybody has a question, you can sort of make your way to the mic, and we can take a few questions. But before we, while you're thinking of questions, I wanted to get a little bit high level again and think about partnerships. You've touched on this. Partnership with the plans, it's a challenge. You work with multiple plans. So could you maybe talk about that? How do you partner with your plans?
So that's, I think, that's been a game changer for us. I did say 15 plans, so that is a lot. But we have, before I got here, our director of quality improvement was told to show up to the meetings with the health plans. She did her best. So what was nice was I had some experience with that, so we now partner together. And we have changed the conversation completely with our plans. We are seen as real partners. It was not like that before. And what we've learned is if you don't ask, you don't get. So we ask. And we've had some amazing partnerships now in the last couple of years. They have actually funded health navigators or interns for us who work on their specific plan, but it's all for all their patients, all lines of business. And we've got HEDIS scores at 90th percentile for Medi-Cal because of that. We have the other things we've done with them. They've helped us with some of our EPIC IT build around quality, like care gap builds. We have plenty of those. And then the other thing that I think was very innovative for us is we worked with a plan, it's a national plan, that has given us a patient experience press Gainey consultant for the last 2 years, who actually is doing patient journey mapping. He goes to all of our clinics, and it's actually increased. We increased our patient experience score for willingness to recommend, which is an entire practice, by 5.5% in 1 year last year, which is very, very hard to do. And we achieved very high levels. The other thing we also just now got funding from them was to actually get fund a patient, a consultant to work with our providers for patient experience. So they're definitely willing to partner with us. We've learned to ask. We can show them data is always important. But I think the other thing that we're partnering on with them now is with one of our health plans, we have now developed an annual preventive visit. So social determinants of health we have to do that. Where we are, that is one of the biggest issues. If you don't fix that, quality is very hard to achieve. So we are actually, we piloted last year for 20,000 patients to do this annual preventive visit, which we built in our health, we built an express lane, which has got social determinants of health, the same tools, and then we've also developed, what do we do if it's positive? That's the main thing. And now we're expanding that for all of our patients annually. They will at least be screened. So that will help, hopefully, our STOH HEDIS measure, which I'm really excited about. And it's forcing us also to work work with our community organizations. And then just through CalAIM and ECM, we have worked on building these partnerships. We have our Institute of Health Equity, they have played a huge role with that as well, where they're helping us identify some of the CBOs who are not full because they've got too much on their plate, so that they're helping us with these partnerships, so that way we can refer our patients. And then the next step really now is data exchange. So if we can do it seamlessly with a referral, can we get the information back? Because that's really what we want to get to. So this is how it's working, but this is just a kind of a snapshot. And I wanted to give a plug in. We have a vendor here, I know, from diabetes, and diabetes is something I'm passionate about. So technology is a very big part of it. So now the next thing is to see how can we get technology for our patients, and also, secondly, even for uninsured patients. The same approach that we took with the other vendors. So that is one of the projects that we're working on this year.
We're getting accumulating a little bit of a line here. Good sisters in the middle.
You want to go to questions? Okay.
Okay.
All right.
Thank you so much for your comments. Monica Soni, Chief Medical Officer at Covered California. Both of your institutions serve many of our members.
Thank you
for that. I heard a lot about innovation, being nimble, but what I haven't heard, and I have to say it's very uplifting to me, is I haven't heard about burden. I haven't heard about burnout. Can you talk a little bit about how, with everything that's already on our providers and frontline folks' plates, the innovation and the change, how are you sort of mitigating against that risk too of kind of, again, further adding to the burnout?
So it's an excellent question, and it's something that, when we're really translating all of these data and regulations and things to the bedside, we have to be mindful of. When we were doing our early exploratory work around how to actually screen for the social drivers of health, how to actually ask the questions at the point of care, we had a pilot going, and the very first day, the physicians walked into the room, and basically it was a mutiny. They're like, we're not doing this. There's too many questions. Nobody has time for this. Like, what do you, but that's an invitation to do it better, right? We got to go find out how many minutes and seconds is it going to take, so that we're not always asking, do more. We want to use technology in a way that everybody, we went to medical school to help people. That's what we all reach back and say, I did go to help people. And so how do we get from I have to I get to? And if we can use technology in that way, so one of the ways that we're doing this in real time is to take one of our clinics in Sacramento. They were, our medical groups out in Sacramento, they were actually able to reach P90 for hypertension control for Black patients by utilizing My Health Online, which is our Sutter Health app. It's actually quite low-hanging fruit. If we can contact our patients and they have a home blood pressure monitor, then we can set up a survey through MHO where they can put their own blood pressure in. And if it's under control, then we're done. So those are the ways, if we can get that information, and across our system, we're really talking from 0 to 3 patients per primary care physician. And so when we break it down to those numbers, then you get to, right? It's 3 people, but it could be 0, it could be 1 on average. But this way, we're able to provide the tools and the technology. We integrate our system. We talked about with technology, if you're going to be digitally nimble, that means you must be operationally nimble. You have to be integrated. You have to be efficient. You can't just build a house of cards with like a cool app that doesn't work. I don't know if anyone tried to order room service in the Bonvoy app. It's a little bit of friction there. We can't have that in healthcare. We just can't. So it forces, I don't know if anyone's listening. Put it on the survey, right? But in all seriousness, these are the things that create just another click and another thing. And if we can get ourselves to, we said IT is health equity. If we can leverage our partnerships within our systems, and that's why when we went to one annual incentive plan at Sutter, now I can call the chief information officer, and he's going to answer the phone and say, okay, how can I help? Because, all of us are it's all of us now. We're all in on the same metrics and the same disparities that we're all working to close. And that's what health equity is to change these fundamentally systematic racist systems to make them better for our patients.
May I just add a little to that? I completely agree with all of that, for sure. And we are on that journey too with IT. I think what's helped us with that, and burnout is definitely real, and it's not just for providers, it's for the whole system. Where we're actually struggling with it right now, candidly, is Calais, because of the complexity of the patient. For our CHWs, it's exhausting, because emotionally, just forget the amount of work. We were just talking about it this last week. It takes sometimes 3 hours to fill out an application for housing, and our patient can't read. So think about how much the CHW has to do, and that's just one patient. So that's just one other part, and we're trying to figure that one out. But I think what's helped us with this, because you have to get buy-in for any program that you start. You can't just say, oh, by the way, I've got a new program, just do it. So just like the social determinants part, I think what's helping us with that, we're trying to do this for 500,000 patients, so you have to think about that. Technology, standardization, and ancillary services. So we're exploring right now to be part of the alternate payment methodology for Medi-Cal for the state of California, which is a huge endeavor. So going away from fee-for-service and going to APM. So I think that would help us, though, because if you have other parts of your team that do the work, so if your paperwork is filled out by somebody else, and it's available for the provider so they can actually look at it. And then also what we've done is we call it an express lane, where, okay, so you're positive for, you're experiencing homelessness. You actually have a referral built in right there that you can actually click it, and it'll go to where it needs to go, and they will take over. So your patient is taken care of, not just by you, but there's a whole team that supports you. So leveraging those ancillary services, so that's where workforce needs to put their money. Because yes, we need providers, but actually what happens outside the walls is so much more important many times. And I think that is what's going to help us with burnout. And again, as we use this terminology, you've heard this before, getting everybody to work at the top of their license. Not everything has to be done by the provider. So I think that is the journey we're on. I can't say that we're completely there. And I think one thing we're working on is trying to get to the level where we can, with APM we can do this, is giving the provider the amount of time that is required to see the patient. Because that is it. You cannot see a complex patient in 20 minutes, at least not do justice to it. So that's maybe that patient needs more. And a patient who's healthy, like I told my CMO, I said, you don't want me to see 19-year-olds for a physical. I mean, I do diabetes, let me do that. So getting the right people to see the healthier patients, so that way that we feel like we can actually manage this, because that is where we are. But that was a great question, thank you.
You give us all hope, thank you.
And do we have time for one more question? We do, okay. Because after this session, we're all going to go back to the main session for the wrap-up. But I'm told we have time for one more question, so.
Okay, thank you. My name is Princess Osita Oleribe. I'm from San Bernardino County. My question is to Dr. Stephanie. You mentioned something about the equity impact assessment. So around the country, there's been so many declarations of racism as a public health crisis, and there's a lot of effort that's been going towards it from all we're hearing, but there's not enough being said about the impact, and I want to know what your EIA entails, the frequency of it, and what it is other partners and people working in the space should go away with in terms of assessing the progress we're making.
Thank you for the question. The equity impact assessment should be done for everything. I mean, if you're creating a program locally in your clinic, you should do it. If you're looking at a strategy for your health system, you should do it. It can be applied both small and wide. And so when we sit in these sort of, senior leadership meetings and we think about strategy for a system, and we have a new CEO, it's very exciting time at Sutter Health, and everyone's presenting their strategy. We're sitting in myself, my partner, and we're thinking like doing the EIA, okay, well, who's being left behind there, and what are we thinking about that, and so everybody, again, this is a way that it can become a part of everyone's job and a part of everybody's language around programming, so it's such that, again, it's not just up to the health equity people to, come and, get on everybody's nerves about it, but that this is just the culture. This is the way that we do business. And so any programs that you're, looking at, any interventions, strategies, again, corporate strategies, all of it you should take this, you can take this tool, just Google it, and really just sit there and just go through and at least think about who might be left behind from an intervention. So it looks at things like, is everyone going to be able to read those great flyers that you put up? Do you take insurance for all of these, complex patients that you want to take care of? Anything in between, but it really is a great tool, and it's a way, again, to create a culture around equity within organizations, health systems, clinics, that does not, again, rely on just the health equity people who do this work every day. We're all here we've all found our people here today, tomorrow, but, we can't do all of this work by ourselves. And honestly, that's what those who don't want this work to be done, that's what they'll hope, is that we all burn ourselves out and stop talking about it. But we need to change the policies, how we govern ourselves, and how we govern each other in order to incorporate and make equity a part of just everyday operations.
Please join me in thanking our wonderful panelists.
Thank you all for your time.
Thank you.